Hello.
Yes, doc, it's visible. Hello, everyone. A very good evening. I am Dr. Sanjana Chavan from the Indian Dental Association, and I welcome you to today's webinar on clinical applications of CBCT in dentistry. Uh, Requesting all the participants to kindly not interfere in between the webinar. Please don't do all these things. Okay, I'm so sorry. I'll continue with the introduction. I welcome you all to today's webinar on clinical applications of CBCT in dentistry. Our speaker today is Dr. Manik Datta, and he is an accomplished oral medicine and maxillofacial radiologist with an MDS from Dr. R. Ahmed Dental College and Hospital, Kolkata. He currently serves as an assistant professor at Zakir Hossain Medical College and Hospital, Murshidabad, and is a life member of IDA, Murshidabad, and IOMR. So, let's welcome to Dr. Manik Datta here. Over to you, doctor.
Hello.
Yes, doc, you're available, audible.
Hello. Hello. Doctor, am I audible?
Yes, yes. You can start with the presentation.
Okay. Okay. Hello. Good afternoon, everyone. Myself, Dr. Moinak. Uh, Dr. Sanjana has already given the short intro of me. Uh, our today's topic is on very important and very needed topic in our current clinical practice life, current clinical dental practice life, that is cone beam computed tomography, the basic applications of CBCT in day-to-day dental practice. Dr. Sanjana has already described about myself. I have completed my graduation BDS from Dr. R. Ahmed Dental College and Hospital, then completed my MDS in oral medicine and radiology. I am life member of IDA Murshidabad branch and life member of Indian Academy of Oral Medicine and Radiology also. So I am, and now I am working as assistant professor, Department of Dentistry, Zakir Hossain Medical College and Hospital, West Bengal. Uh, that's the brief intro. That's my college, the first dental college in India. That's Dr. R.M. Dental College and Hospital. And now my workplace currently. Before starting our today's discussion, how the CBCT reports look like, we have to know how the CBCT reports look like. Here is the summarized form of classical CBCT report, that including all that important summarized points, including the patient details, the technical details, the necessary clinical informations, and the clinical findings. We will discuss thoroughly how the CBCT reports and what are the basic components. Then we can understand the rest of all our today's presentation or the discussion. The patient details, including the basic details of the patient, including the name, ID registration number, date of examination, and the age, sex of the patient, and the most importantly, the reason of the scan, the indication or the basic reason of scan. Why I am scanning? What is the basic necessity of doing the CBCT? The most important another thing is the technical details, that include what the machine we are using, what is the field of view, that is small. The small field of view is needed for implant planning. The medium view, including the single arch or both the arches or large FOV, means that is the total craniofacial view, mainly the skull reconstruction and the total craniofacial view or reconstruction. The voxel size we will later discuss on the kilovoltage peak, the milliampere, and the other exposure parameters. The scan region. What is the scan region? The scan region determines the field of view, region of interest, basically the region of the interest. There is the radiographic interpretation of region of the interest is known as field of view. The scanning region may be maxilla, mandible, single arch, both arch, the TMJ region, the maxillary sinus, the full craniofacial reconstruction, etc. The image quality is proper, the resolution is proper, if there is any noise or artifact is present, etc. Mostly, we have to mention the short but needed clinical information about the patient, which will help the radiologist, the maxillofacial radiologist, to doing the report for clinico-pathological and radiological correlations. The finding including the teeth and the alveolar bone, that include the status of the dentition, if there is any caries present, the normal thing, the basic things, including the caries present, there is endodontic treatment, RCT done or not, one wall, two wall, or three wall defect, the periodontal bone defect is present, the bone status, there is angular or horizontal bone loss is present or not, if there is any periapical pathology is present or not, there is any kind of the periapical radiolucency present or not, the sclerosis, bone external or internal resorption is present or not, the close proximity towards the adjacent structure, inferior alveolar canal, or in the upper jaw, maxillary sinus. Second point, that is upper arch or lower arch. There is how much amount of the cortical bone is present, how much amount of the lamellar or medullary structure is present. There is any presence of the cyst or tumor, any kind of the maxillofacial trauma, the buccolingual cortical expansion or not, there is external or internal resorption is present or not. We have to mention all the things. First, the teeth and the alveolar bone related, and secondly, the jawbone related, means the gross appearance. Then we will summarize all the radiological finding and mention in that section. Is the Cursor is visible. You can see the cursor. Hello. Hello. You can see the arrow. Dr. Sanjana. Hello.
Yes, doc.
The arrow is visible. You can see the arrow, na?
Yes.
The last, the recommendation. There is any kind of the clinical, surgical, or medical correlation, and which section I have to refer. In which section I have to refer. And last but not the least, there is the maxillofacial radiologist details, the name, qualification, etc., registration number, etc. So the basic summarize that can be implant report, that can be endo report, then that can be maxillofacial trauma report, that can be any kind of the maxillofacial pathology report, but the basic parameters are the same. We necessarily have to mention all the points I have described in that slide. Then we will go to the deep and individually we will thoroughly discuss about the rest parts. The today's discussion, I would include, we will include the introduction part, the historical background part, the principle, the component of the image production, including the generation, detection, reconstruction, and last step, the archiving, export, and distribution. We will mention about the clinical consideration, about the image noise, the advantage and limitations of the CBCT, the volume preparations of CBCT. We will not discuss in detail about the volume preparation. That is totally the technical part. Actually, basically, from the general dentist scenario or the maxillofacial radiologist scenario, we have to understand the basic radiological things, the clinical thing, not the physical, not the physics part thoroughly. But before going to the clinical correlation, clinical radiological correlation, we must have the basic knowledge of the basic physics knowledge of the CBCT. For that reason, we will discuss in very short and summarized way about the physics part, the clinical application, and lastly reference. How the CBCT machine look like. That is the ideal Carestream CBCT machine, the CS9600. That may be Carestream software, CS7600 also, that is the updated machine. That component, the X-ray source, the detector part, there is bite block or bite notch, the ear adapter, and the control panel, which can upwards or downwards, exposure setting, the time limit, the which part to be scanned, the maxillary, mandibular part, all the basic things in the control panel. Here also that is the control panel, the ear adapter, the bite block, the X-ray source, and the detector. That is mainly the flat panel detector. Presence of collimator is also there. That will rotate around the patient. There is absence of any kind of the gantry in the CT. The basic difference is in the CT there is presence of gantry, and the patient must have to lie down. But in the CBCT, basically nowadays the patient will stand, and both the X-ray source and the detector will move around the patient along the center of rotation, along the center of axis or center of rotation. That is the basic CBCT software, reporting software look like. There is several parameters. There are several tools. We can detect that is the Carestream 3D software. There are numerous type of the software, Vatex software, Panamica software. I am showing the Carestream software. There are numerous type of software. You can pick any of them and easily we can report. So there are various tools, the measuring tool, we can assess from them. So now, before going to the core of the presentation, we have to know what is CBCT. What is cone beam computed tomography? If we split the word CBCT, we can say the cone beam computed tomography means the where the cone shaped or pyramid shaped source of ionizing radiation is there. The beam, what is beam? X-ray beam. CT, computed tomography. The tomography, that means the sliced or section image, and the computed tomography. Tomo means slice or section, and graphia means the image or picture. There is sliced picture generated by computer regeneration, cone beam computed tomography. That is the 3D imaging modality that is introduced for the maxillofacial, some kind of the ENT purpose also, over the conventional 2D technique and medical CT. The medical CT was available in the market, but what is the necessity of introducing CBCT? The cone beam computed tomography. What is the importance of cone beam computed tomography over medical CT? And here we go to the next slide. Before describing all the things, we have to know the history part also. In the year 1967, Sir Hounsfield first developed the CT scanner, not the CBCT, and he considered as the father of computed tomography. In the year 1982, the first CBCT scanner was built up. The first CBCT scanner was built up in Mayo, Canada, for angiography, not for the maxillofacial purposes. In the year 1990, the CBCT was introduced for oral and maxillofacial radiology. Here comes the maxillofacial radiology purpose. Dr. Arai and Dr. Mozo. Dr. Arai in Japan and Dr. Mozo in Italy. They first introduced or developed the CBCT for specifically for dedicated the OMR purpose. And that was commercially available on later on in the year 1996 in European market and 2001 in US market. Around after 2000 it comes to India, around the 2005 or near about days. So what is the basic principles of CBCT, cone beam computed tomography? We have already described, we have already discussed all the things, the basic things in previous slides. Just we will go shortly and in summarized way. That is the X-ray source. I have already told out. That is the center of rotation, axis of the rotation. That is the skull, human skull, our object. That is the flat panel detector. There are two types of the detector. We will later discuss on that. That is the CCD, charged coupled device, and flat panel, FPD, flat panel detector, not the fixed partial denture. That is FPD or flat panel detector, consisting of silicon transmitters, several things. So the X-ray beam shape is that is cone shaped or pyramid shaped, but in the case of medical CT, that is fan shaped. That is fan shaped. The basic difference, how it works: patient is position, the standing position, field of view is fixed based on the region of interest. How much amount of the area should we scan? That is the region of interest. That is the clinical region is known as the region of interest, and the region of interest determine the field of view, means the FOV, the radiological aspect of RY. Then X-ray source and detector rotate around the rotation center, fixed within the center of the region of interest. During the rotation, there are formation of the several, we are cutting one thing in several slicing image. The multiple sequential planar projection images is obtained. Each and every word is important. Multiple, numerous numbers, sequential, planar means single plane, the projection images. and they are individually referred to as basis or raw images or frame images. And there is formation of the several hundred two-dimensional images, not the three-dimensional. Two-dimensional images are formed, and later on they are constructed by recon software. That is the X-ray source, that is the detector, and same thing, that is the skull region of interest or FOV. That is the physics part, actually image acquisition. Yeah, 2D detector arrays present. There are formation of the several hundred raw data 2D projection, then reconstructed by recon software, and we view in the then 2D slice section and 3D reconstruction in DICOM file by the DICOM file. The complete series of the image is referred to as projection data. The bulk of the raw images, when gathered together, the compiled bulk of the images is known as the projection data. And then we form the main reconstruction, and by setting the volumetric data. There are numerous recon software available nowadays in the market. We will discuss later on. There are basic three source, X-ray source, detectors, and the recon software. Three basic component of our CBCT. How the X-ray is generated, we have already mentioned about all the things. I am not repeating. The CBCT machine is look like that. The X-ray generator. The actual exposure time is up to 50% less than the scanning time. Means how much time the patient is standing in the machine, actually not the full time we are exposing the patient by the radiation. Near about 50% time actually is needed for the exposure, and we follow the ALARA principle, means as low as reasonably achievable. We all know about the ALARA principle, and like the other the X-ray, the IOPA, and the panoramic view, we also follow the ALARA principle here also. The scan volume, if we follow the basic picture, there is source of the X-ray, there is presence of filter, that is also bow tie filter, the specialized type of filter, the collimator also, the detector, flat panel detector is also present, and the scatter correction, we have to correction the scatter also, or to prevent the secondary radiation or the scattering radiation. We have to determine we have to mention the FOV. We have to mention the size of the FOV for definitive area resolution. What is that? There are basically mainly 4 types of the FOV nowadays we recommend. What are they? We are starting from the lesser one, means the smallest one, that is the localized, means single quadrant, that is less than equals to 5 centimeter. Then after single quadrant, single arch, that is 5 to 7 centimeter, that is 5 to 7 centimeter. Then both the arches, that is 7 to 10 centimeter. For this writing, you can't say, I think. You can't see, I think. Acha. And last but not the least, that is the maxillofacial. That is the maxillofacial. That is the maxillofacial. The whole reconstructed area, the largest FOV, that is 10 to 15 centimeter. Now we will summarize the physics part as soon we can. The X-ray detection, the X-ray detection detector are basically of the two type we have already discussed earlier. That is CCD was used in old days, but nowadays recently all the detectors are FPD or flat panel detector type. If we concentrate on this picture, there is numerous photodiodes present. There is numerous photodiodes present and conducted by scintillator. Scintillator and X-ray conversion is happen in the that scintillator region. There is several number of the silicon sensor is present. In the 3D, in the OPG or another 2D images, there is formation of the pixel, means 2D representation of the equal boxes, the 2D representation. But in the 3D images, there is voxel or the 3D cubicles. There is numerous 3D cubicles that are united from the mainly the field of view area. First, in the sliced section, we get the pixel images, and then we convert it to the voxel images. What are the clinical consideration? We have to follow the exact same things, same conditions as we apply during the panoramic radiograph or the external radiograph. The ALARA principle must be applied, must be followed, the principal criteria. From the patient preparation section, we can say we have to use the lead apron, lead thyroid collar. We all know all the things, the basic things, actually, the basic radiologic things. The external, any kind of the external radiology scan, we have to apply all the things, we have to maintain all the things. Before the scan, all metallic object, including the nose pin, ear ring, the metallic clip, any kind of that thing should be removed from the patient body. What should be the position of the dentition? Dentition, it is desirable that the dentition be separated but held together firmly. Held together firmly. This can be done with a tongue depressor or something. We have to place a cotton roll or tongue depressor in interarch position. The dentition should be separated, not in interocclusal position, but hold together firmly. The separation of the teeth is useful in single arch scan, where the scatter metallic restoration is opposing edge arch can be reduced. The basic things, actually. The most important thing is image protocol, means the tube current, milliamperage, and the kilovoltage peak. We have to mention or measure all the technical parameters. Actually, they are basically fixed in nowadays the CBCT machines. Actually, we have the all the thing is we can the modify by the control panel, but the nowadays in several machines they are fixed. The exposure setting, the adjustment of KVP has a greater effect than milliamperage. The KVP has greater effect than tube current. If we follow the sequentially, the milliamperage is increasing. The sequentially the milliamperage is increasing, and sequentially the KVP is also increasing. And if we summarize this image and this image, that is 2 milliampere and 60 KVP, and that is 15 milliampere more tube current and more KVP, that produces the better resolution image, the better heart tissue resolution image. The last step, the archiving export. Acha, that is actually the glenoid fossa, that is the articular surface of the condylar head, uh, that is the meniscotemporal spaces. Actually the articular cartilage can't be seen in CBCT, that is a soft tissue component, we can see only by the MRI. The archiving, export and distribution, the last stage. The volumetric data is set by analysis the volumetric data. What is the volumetric data? We have to gather the all the volumetric data, and the summarized form is projection data, and then the projection data we will compile all the projection data, and then we will convert it in 3D perspective by several kind of the recon software, and we will see by DICOM image file, in which format the image will comes to dentist in DICOM file format. DICOM means digital imaging and communications in medicine standard file format. Now everything is some limitations here also. In the case of CBCT, how the what is the limitations? The artifact or the noise in such limitation or such distortion or error that is unrelated, that is unwanted or unexpected. We don't want that type of the image, that type of the things. How the artifact is produced, we'll discuss now. Artifact can be inherent artifact, the procedure, it's the procedure related artifact, introduced artifact. The artifact is introducing unwantedly or wantedly. The patient motion artifact, during the scanning, if the patient is moving, if there is presence of, if the patient is not removed the metallic object, that is the introduced artifact. Inherent artifact, if already the machine have any kind of the procedural error, any kind of the defect, the procedure related artifact, if the technician is not handling properly. Introduced artifact I have already mentioned. Patient motion artifact I have already mentioned. That is the scattering radiation. The due to several scattering radiation, the artifact is noise is produced. There are two terms, cupping effect or and beam hardening. We will not go to the details. The due to presence of the superimposition of the unwanted thing, there is radio density and the cup like radio density followed by the rim of the radiolucency that is present, that is the cupping effect. The linear, the ridge like, the radiolucent band or area, that is beam hardening. Advantages of the CBCT. What are the advantage? Basic advantage, it occupies the smaller space when we compare to conventional medical CT. The cost is almost lesser when we are comparing to medical CT. We can process, the processing speed is faster, and the radiation exposure is much lower if we compare with medical CT. What is the, how much time the radiation is decreased? In the case of computed the CBCT and multi-detector CT, in the case of CBCT, we have already discussed the four types of the FOV: small field of view, medium field of view, and large field of view. In the small field of view, only the less than equals to 5 centimeter, means including the single quadrant. The medium view, that is the single arch or both the arches, and craniofacial view including the total reconstruction of the total skull view, craniofacial view. The 50 microsievert, the 50 microsievert, that is the median effective dose is 50 microsievert and equivalent background exposure. In how much days? In case of the multi-detector CT, multi-detector medical CT, where it's produced 650 microsievert, but in the case of large FOV, when we are using the large FOV, that is produced the 120 microsievert, means the radiation is almost 1/5, the patient radiation exposure is almost 1/5 when we are comparing to conventional medical CT. If there is some kind of advantage, the limitations is also there. What are the limitations of CBCT? There is less soft tissue contrast when we are compared to CT scan. Why soft tissue contrast is less? Because the detector is larger, because due to larger shape of the flat panel detector is used here, so the detector size is larger, so the chances of the producing scattering radiation is more, image artifact chance is more, noise production is more, so the soft tissue contrast is less, resolution is less. We have already discussed all the points. Just in this slide I have summarized all my previous described thing in single slide. The CBCT uses the cone beam or pyramid shaped beam. The CT uses the fan shaped or very thin slice of the beam. The CBCT, the lower soft tissue resolution. In the CT, higher soft tissue resolution. Why? Due to the larger flat panel detector shape, size. The lower radiation exposure in CBCT, higher radiation exposure in CT scan, medical CT machine. Smaller space is needed for keeping the CBCT machine. The larger space is required for medical CT machine. We have already discussed the soft tissue resolution, the better contrast in medical CT. The CBCT cost is lesser, medical CT cost higher. The voxel resolution isotropic, there is production of isotropic, means equal shaped cubicles. There is anisotropic, means equal shaped cubicle unit is not present. Can we use the CT for implant planning? No, not suited for implant planning, any kind of the endopurpose, any kind of the all the things. Only maxillofacial pathological things, the fracture trauma we can use. But the core dental things, we can't use the CT when in short span of the interest. Now, how can we interpret the CBCT? The basic interpretation of CBCT. Before going to the interpretation part, how can general dentist, how a normal general practicing dentist can interpret the basic things of the CBCT when we are seeing the scan? There are basically three anatomical landmarks, the three anatomical planes. Sorry. There are three anatomical planes, including the transverse or axial plane, the frontal or coronal plane, and the sagittal, mid-sagittal plane. We have already discussed the sagittal plane, the mid-sagittal plane, the frontal or coronal plane, and the transverse or axial plane. They are the basic anatomical landmarks, I can say. They include we all know the basic structures, we all know the basic skull structure, including the supraorbital margin, infraorbital margin, we all know I will not go to the deep, just we will discuss on the summarized way. That is the glabella part, the nasal bone, the in the midline perpendicular plate of the ethmoid, the vomer bone, anterior nasal spine, the alveolar process, the whole thing as alveolar process of maxilla. In the periapical region, 4 and 5 first and second premolaries, mental foramen is present. That is the symphysis menti, symphysis area, the symphysial area, the lower border of the mandible, uh, that is not showing actually the coronoid process in that region. The coronoid process, the head of the condylar process, that is the sigmoid notch, we can see. That section is not actually present. Acha, the supraorbital foramen, infraorbital foramen, infraorbital foramen is also present. The sphenoid, the part of the sphenoid, we can see. The part of the lacrimal bone, lacrimal fossa gland, we can see. Now the mid sagittal view, uh, that is the lodging of pituitary gland or sella turcica, and the fossa is hypophyseal fossa. Pituitary is also known as hypophyseal gland. And the adenohypophysis, neurohypophysis, I am not going to the details. The cribriform plate, the inferior nasal concha, the vomer, anterior nasal spine. We have already discussed all the thing. The myelohyoid ridge, we can see the hyoid bone, greater cornu of the hyoid bone, the lingular triangular projection, lingula, the mandibular foramen, that is the styloid process. Styloid process responsible for the elongated styloid process is responsible for Eagles syndrome. The occipital bone, there are four basic bone: occipital, parietal, frontal, temporal. The hypoglossal canal, the external acoustic meter. So we all know all the things. The transverse or axial view, there are two transverse or axial view. The exterior view and the interior view will not go to the detail. The interpalatine suture, hard palate, soft palate, the sphenoid bone, the arch of zygomatic process, the foramen magnum, the large foramen magnum, the occipital bone, the carotid canal, foramen oval, spinosum, uh, rotundum, oval, and spinosum, the Ross structure ROS, the vomer, the interior view, the perpendicular plate of ethmoid, the crista galli, the cribriform plate, the laser and the greater wing of sphenoid, the sella turcica means hypophyseal fossa, the foramen magnum, the jugular foramen, internal jugular, and the jugular foramen, the squamous part of the temporal bone, the both side in the parietal bone and the occipital bone. We all know the basic structures actually. If we the how this anatomical structure, skull structure look like in the CBCT image. If we see the CBCT image, if we find the something abnormal, we have first to know what is normal. Then we can identify or separate or detect the abnormal thing. We have to first know the normal things. What is normal thing? How the normal skull look in coronal view CBCT. Now the coronal view CBCT. That is incisor and the canine level. In the incisor and the canine level, what structures we can see? The anterior nasal spine we have already discussed. The nasal bone, the the nasal bone, that is coronal or frontal view. Frontal view. The incisor and the in the incisor and the canine level. In the premolar level, between the 4 and 5, we are taking one slice or section. The sinus appeared. That is the infraorbital foramen. That is the orbital cavity, we all know. The perpendicular plate of ethmoid in the middle, superior nasal concha, inferior nasal concha, anterior nasal spine, that is the hard palatal floor, that is the section, that is the both side of the cortical plate, buccal cortical plate, lingual cortical plate, and ID canal, inferior dental canal, inferior alveolar canal. The soft tissue shadow is the poorly identified. The soft tissue shadow is tongue, the hard palatal floor, the maxillary sinus, the ethmoidal sinus, etc. In the molar level, we can see that structure. What is the structure? Superior, middle, and inferior nasal concha. There are three concha present. The zygomatic, the part of the zygomatic bone arch buttress here present, the soft tissue shadow of the tongue, the hard palatal floor, anterior nasal spine and vomer, medial nasal septum. The lacrimal part is can't visible here. Uh, what can we see in the coronoid process level? Mainly the hamular notch, to see the hamular notch and the superior tip of the cornea, the coronoid process, where the coronoid process level we can see the this area. This area is the maxillary sinus level. In the to detect the oropharynx, that is the oropharynx. There is nasopharynx, oropharynx, and the that is the oropharynx. Actually, we can't see the nasopharynx area, and there are two plate, the medial and lateral pterygoid plate-like structure. In the condylar level, we can see the foramen oval there, the body of sphenoid, the articular surface of the condyle, the glenoid fossa, the articular surface of the head of the condyle, the glenoid fossa, and the squamous part of the temporal bone, and that is the meniscus temporal space. The articular cartilage is not seen. We can't see in the CBCT. CBCT, only the hard tissue structure we can see. The squamous part of the temporal bone. Vertebral level is not actually required very much. Now, the axial view. The axial view. There is red lines. Anyone have drawn the red lines? Whatever. The axial view. The frontal sinus level. In the frontal sinus level, the crista galli can be seen, the orbital cavity can be seen, the frontal sinus can be seen. In the mid-orbital level, most important structure, that is the nasolacrimal duct, can be seen. That is the nasolacrimal duct can be seen. That is the squamous part of the temporal bone, greater wing of the sphenoid bone. We will not go to the detail. In the inferior orbital foramen level and above and below the inferior orbital foramen level, the maxillary sinus, the basic structure, the maxillary sinus, the zygomatic arch, if there is any fracture or not in the zygomatic arch, the inferior orbital foramen, we can detect, the carotid canal we can detect, the aqueduct of Sylvius, the ventricles are present, the zygomaticotemporal suture, the any disjunction of any kind of the suture is present, the maxillary sinus, their walls, anterolateral wall and posterolateral wall, medial wall. We can see all the structure below also. In the maxillary sinus level, that is important. The maxillary sinus level, we can see the both the plates, the medial and lateral pterygoid plates, the head of the articular surface of the condyle, the incisive canals, medial nasal septum is also present. In the dentition level, the mandibular arch, the maxillary arch, mandibular arch, the tongue shadow, the maxillary teeth. There is maxillary teeth, the palatine canal, if there is any cystic degeneration or not. We can detect all the things. In the mental foramen level, there bilateral presence of mental foramen in, and that is the lower border of the mandible. That is the series, the lower border of mandible. That is the buccal side. That is the that is the lingual side. Hmm. Uh, the presence of mental foramen, the soft tissue shadow of the tongue, the airway space, oropharynx space. We can't detect nasopharynx so well. The part of vertebral column, the C3 vertebra, the here also oropharynx, the hyoid bone, greater cornu of the hyoid bone, the base of the lower border of the mandible, also present. Sagittal view, what structure we can see? In the sagittal view, there are two levels, that is condyle level, head of the condyle level, and mid sagittal plane level. We'll summarize that section so early. We can enter in the main part, that is the application part, rapidly, but they are also important. Actually, we have to understand the basic things also, then we can understand the scan also. The nasopalatine, first focus on the mid sagittal plane. uh, we are almost familiar with the lateral skull section, the sella turcica, that is hypophyseal fossa. uh, can the red lines can be deleted? The participants are requested to delete the red line you have mistakenly made, if you have made. Acha, that is the oropharynx part, the epiglottis part, that is the genial tubercle, greater cornu of the hyoid bone, the nasopalatine canal, the the perpendicular plate of the ethmoid bone. Condyle level I am not discussing. And lastly, the mid sagittal area of the neck, the soft tissue resolution, nasopalatine canal. Nasopalatine canal. That is the hypophyseal fossa, sella, the sphenoidal sinus, the frontal sinus. The sinus are actually seen, the nasopalatine canal. Now the most important part we are entering now, that is the clinical applications of CBCT. What are the basic clinical applications? Nowadays we can apply. Why CBCT is mandatory nowadays? Why CBCT is so needed? Why CBCT is so important to us? Why the basic knowledge of CBCT is important, needed to every dental clinician? Now it is actually CBCT is now is indicated in the each and every branches of dentistry, each and every branches. In it can be the implant planning, it can be the endo purpose, it can be the for the disimpaction surgery, it can be any kind of the orthognathic surgery, it can be any kind of the pathological lesions, for surgery of the any kind of the pathological lesion. It can be the for to detect the missed canal in endopurpose, to detect the internal or external resorption, unwanted internal or external resorption. Uh, Suppose, let's take one example. In recently, I have obturated a upper six, the upper six tooth uh, nicely, but the IOP are showing there is nice obturation, there is no shortening, nothing, but the patient is complaining after 1 month there is still presence of pain. The pain have not diminished after a successful RCT. The pain is not diminished. So what is the benefit? Actually, in the interior scenario, in the basic town area, the CBCT is not uh, the everywhere available. So how can we prescribe CBCT? We have to adjust with the intraoral, the IOPRs or the OPGs. And when I have prescribing CBCT enough, and then I have prescribed single CBCT for the tooth. And when I am seeing the CBCT for the single tooth, there is presence of missed canal. There is presence of MB2, that missed canal, and also the present the mild periapical pathology in the palatal root also. And accordingly, I started the retreatment procedure in the OPG or in the IOPR. That is so good, the obturation qualities, there is no problem. But when I am seeing the CBCT, there is actual the scenario I have found. One or one another case, the nice obturation, nice thing in the lower 7-1, lower 7 tooth. But when the patient is biting, the patient is shouting with the pain. There is no any kind of nothing fracture, no dental fracture, nothing. But when I am after seeing the CBCT, there is presence of micro oblique fracture. The micro oblique fracture is present. Here is the necessity, the increasing importance of CBCT nowadays. That cost near about 1,500 to 5,000. It can be up to 6,000 in metro city or near about. But uh, the if the FOV is small, if the needed area is small, the cost is also less. If the FOV is greater, the cost will be more. The basic thing. So we can prescribe. The patient is paying about 5 to 10,000 for RCT procedure. We can easily advise around 2,000, 2,500 for CBCT. He or she can easily pay nowadays in when we are practicing in the metro cities or in normal area also. So it is increasing day by day. Several scratch marks is already present in my we have already described the basic applications in general dentistry, endo, OS, perio, implant planning, the forensic dentistry, sports dentistry for the research purpose, any. For, for the implant planning, to identify the root canal morphology accounts according to Wins classifications, the several orthognathic surgery to rule out the horizontal or vertical growth pattern, to uh, before the BSSO bilateral sagittal split osteotomy means orthognathic surgery, the mandibular third molar disimpaction surgery to assess the wear lines, and the difficulty index for the TMG imaging to assess any kind of the internal derangement of condyle is present or not, any kind of the TMJ erosion, TMJ sclerosis, any kind of the maxillofacial cyst or tumor or any kind of the pathological lesion is present or not. In the every section of the dentistry, we need now CBCT. It is becoming an important tool day by day nowadays. First, the larger application section is, we will start with dental implantology. We all know the basic part of dental implant, that is the crown part, the abutment part, the implant screw, and the fixture part. The fixture part. The CBCT in the implant planning, the CBCT has revolutionized nowadays in its implication part. In the pre-surgical assessment section, CBCT is now much needed, so important tool nowadays for the pre-operative surgical assessment to assess the how much amount the bone is present, the quality of bone, the quantity of bone, the density of the bone. We can also advise DEXA scan, but that is costly. Bone densiometry is there. The proximity towards the anatomical structure, that is the in the case of the upper arch, in the maxilla, that is the maxillary sinus. In case of the lower arch, that is the ID canal, inferior alveolar canal. Inferior alveolar nerve actually. According to the Carl-Misch classification, we all follow the classical classifications given by Professor Carl-Misch, and he classified the bone in 4 types. For the implant planning, he classified the bone in 4 types, depending on the amount of the ratio between the cortical bone and the trabecular or medullary bone. The 4 types of the cortical bone is looking. In the case of type 1, there is largest amount of the presence of cortical bone. In the case and the lowest amount of the central, in the core, the lowest amount of the medullary bone is present. And accordingly the amount of the cortical bone is decreasing, and simultaneously if we go from type 1 to type 4, accordingly we will find the amount of the cortical bone is increasing. From the amount of the cortical bone is decreasing from type 1 to type 4, and the amount of the trabecular bone is increasing from type 1 to type 4. But the quality of the bone is degrading or decreasing. The ideal will be type 1. The ideal will be type 1, and the worst will be type 4, because the cortical plate is more dense, more ossified, the more solidified, the more potential to retain, the retaining capacity will be more. The mineral density is more also. Now, where the basic function of CBCT, basic necessity of CBCT, why CBCT is needed before an implant placement? It is needed where for the virtual planning. Nowadays, before placing the implant in practical scenario or in the patient mouth, we have to first plan virtually. And we make a 3D model implant stent. We assess the position of the ID canal, the ID nerve, the distance from the alveolar ridge, the distance between the alveolar ridge or alveolar crest and the superficial surface of the ID canal. What distance should be kept from the lower surface of the implant surface and the ID canal? What should be the distance in between when we are placing multiple implants? What should be the distance between the floor of the maxillary sinus and the alveolar crest? What should in the upper jaw, when we are placing the implant, in the case of zygomatic implants, what will be the angulation? What is the position of zygomatic buttress? What is the bone density? that would be the flapless implant or not. The implant will be placed immediately or not. There is multiple implant in the patient mouth. What will be the inter-implant distance, the distance between the implant and the normal tooth, all the things we have to measure. And the stent, the actually nowadays we made a first in the implant case, first the actually the impression, digital impression is taken from the patient mouth, then the digital impression is saved and referred to the radiologist. Then we plan for uh, planning for a stent, virtual stent, and then we form the virtual stent by 3D printing uh, with clinico-radiological, all the aspects we have to monitor. After monitoring all the clinico-radiological aspect, the proximity towards the anatomical surface, the bone density, which type of the bone is present or not, the quality of the bone, how much amount, the quantity of the bone, how much amount the bone is present, if there is any necessity to bone graft placement or not. After all the procedure, we are making a stent, surgical stent. There is several multiple holes present in the stent, the surgical stent, and we place in the that surgical stent into the partial or fully edentulous end. And just it is nowadays transforming into flapless surgery, because exactly the if we follow the vertical course, the vertical, and make the drills, make the angulations in such the way the implant will be positioned nicely, superiorly, properly, in such a angulation that that would be so correct, so correct. That's why the chances of the errors is so limited if we use CBCT for implant planning. Actually, nowadays, anyone not use the OPG in implant planning, and it is not recommended also. By assessing the OPG, the implant placement is not nowadays recommended. There is option of CBCT. Actually, the implant, one single implant costing around 20 to 25,000 or more than that. The patient can afford the price of CBCT also. The position of the ID canal, that is the inferior surface of the implant screw, that is the distance between the superior surface of the ID canal and the inferior surface of the implant placement, that is the gap we have to mention, we have to follow 1.5 to 2 millimeter. The uh, the angulation that is placed more buccally or more lingually, we have to assess by uh, analyzing the software, the inter distance between placing multiple implant, the axial inclination, what will be the axial inclination, that will be actually the implant. In the case of implant, the natural tooth, uh, the implant, the axis of the implant placements will be perpendicular to the natural tooth present. The parallel to the natural tooth present, the parallel to the presence of natural tooth. And all the important uh, anatomical structure close proximities should be considered. The presence of ID canal. ID canal should not be pierced. There should not be the inferior surface of the placed implant in upper jaw should not be in the sinus. Why? The sinus will, the body will uh, arrest him. The body will recognize that implants go as the foreign body, and the sinusitis will gradually produced. And in case of piercing the alveolar, the inferior alveolar nerve, there will be paresthesia, temporary or permanent paresthesia. If bone graft analysis, we have to monitor if there is one wall, two wall, or three wall defect. Any autograft, allograft, xenograft is required or not. What are the height of alveolar crest? Clinically measure the biological width also. The volumetric analysis of the bone, the density of the bone, we have to assess, and after measuring all the data, all the parameter about the bone, we have to place the implant. The osseointegration and the with the lamellar surface of the bone happen so in so mannerized way. Now we have completed the implant. Now the most another important thing is oral and maxillofacial surgery. In the case of third molar disimpaction surgery, in the case of extraction of the third molar, the impacted third molar, we have to assess the proximity, close proximity to with the anatomical structure, means inferior alveolar canal. It can be mesioangular impacted or vertical or horizontal or distal angular. So first we have to monitor their coinciding, overlapping with each other or not. First we have to monitor this thing. Secondly, we have to monitor the about the wear line, the difficulty index, the if the pathway, the trajectory of the inferior alveolar canal, how it is going forwardly, it is contacting or not, what will be accordingly the point of the elevator application we can monitor. In this type of the case, the distal guttering we can assess how much amount of the bone we have to gutter, we have to cut. There are several things actually. Are several things. The close proximity with the last present and the adjacent molar means the second molar tooth, which what is the angulation of in between them, all the data. What is the basic requirement of CBCT? You can say we can gather all the data for panoramic radiography or IOPA. What is the importance of giving CBCT? The cost is more. Why we have to advise? Necessity is there. Why? Because we can't assess the tooth is positioning more buccal angulation, or in more lingual angulation, or that is lying obliquely or not. What is the relation with the retromolar trigone? How much amount of the bone is there? We have to monitor all the things. The pathway, the trajectory with the actually in the OPG, the the ID canal will be in the just one radiolucent band-like structure. We can't assess the pathway. We can't assess the dimensional pathway of the inferior alveolar canal. But if we uh, see the CBCT, we can thoroughly assess all the clinical information that is needed. Maxillofacial trauma, fracture, we can assess the LIFO type 1, the type 2, type 3 means the craniofacial disjunction, and the all the fractures, nasoethmoidal fracture, zygomatic arch fracture, all the things, all the things. The purpose of giving the medical CT is fulfilled, but with the less radiation exposure. That's the importance of CBCT. Now the temporomandibular joint assessment. Mainly, that is the panoramic radiograph, that is the lateral TMJ radiograph, that is the CBCT sagittal, mid sagittal view, CBCT 3D reconstruction view, that is the frontal or coronal view, and frontal TMJ view, open close view actually. So what is the benefit of giving the CBCT in TMJ cases, TMJ pathology cases? Actually, when in which the clinical scenario, what are the basic clinical scenario in which cases we need CBCT? When we are finding that there is decreased mouth opening, there is stiffness of the jaw. Not, I am not telling about the WSMF cases. When there is we are palpating the basic masticatory muscle of mastication, and found pain during palpation of the lateral pterygoid, uh, palpation during masseter, and evolution any kind, if there is presence of any kind of the sounds, clicking, popping, crepitus, lockjaw, history of the lockjaw, in that cases we must have to prescribe the CBCT. Why it is needed? We have the option of OPG, we have the options of TMJ open and close view. Why CBCT is needed? Why I will spend a several amount of money on CBCT? What is the necessity? Yes, necessity is there. What we can't assess there is any kind of the oblique resorption of the condylar head. The head of condyle is present or not. If there is any derangement is present or not. We all know the basic structure. I am not repeating this, but for the better understanding, I am just telling the basic anatomical structure. That is the articular eminence, the glenoid fossa, the articular eminence, the glenoid fossa, the articular surface of the head of the condyle. During the opening, that articular condyle moves forward, and during the closing, the articular surface of the head of the condyle goes backwards. That is the basic thing actually, the occlusion, during the occlusion. But to assess there is any deviation during the opening, the condylar deviation during the opening or not, we have to assess all the things. Any TMJ erosion is present or not. That is the clinical, they are the clinical findings that will we have to assimilate with the radiological findings also. Now the craniofacial surgery, in the case of cleft lip and palate, in the case of uh, uh, early growing babies, the natal and the in the neonatal conditions, what is the actual bone defect? What is the actual bone defect? How much amount the bony defect is present? To assess that, what are the hard palatal defect? The hard palatal defect is present. We have to assess all the things. When we have to place the graft, how much amount the bone graft we have to place, all the clinical data we can detect from CBCT. In case of orthognathic surgery, BSSO, bilateral sagittal split osteotomy, if there is the class 2 skeletal occlusion, the class 2 the skeletal occlusion means there is maxillary prognathism, the skeletal class 2 means that is the horizontal growth pattern. In case of skeletal class 3, the flat growth pattern or the mandibular prognathism. In all the types where there is necessity of bilateral sagittal split osteotomy, in case of maxillomandibular disjunction, various types of the syndromes, the bird-like faces, the in the case of hemifacial microsomia, several facial asymmetry. Before surgical planning, the surgery will be guided by CBCT. How much amount of the bone we have to operate, we have to cut. There is presence of lateral cephalometry, lateral skull view. What is the importance of giving CBCT? What is the importance of prescribing CBCT? CBCT prescribing is needed. Why? Superimposition of right and left side. If there is any pathology related to only the left, there is any deviation, is generally in case of orthognathic surgery that is less, but it may be if there is unilateral involvement. So that is the superimposition of that thing. To avoid the superimposition, we have to prescribe the CBCT. Now, another important thing, that is CBCT in endodontics. Endodontics. To assess the missed canal, I have already described my clinical experiences in the mixed MB2 canal, the mixed MB2 canal. We all know in the case of upper 6 or 7, there is mesiobuccal, distobuccal or palatal canal, the usual classical canal. But if we actually see the CBCT, we can find several accessory, the several extra canal, accessory canal, which causing the post-operative pain after a successful RCT, the considered successful RCT, the missed MB2, missed mid-B canal, missed mid-B canal, all the things we can assess. Periapical pathology. The most common thing is periapical pathology, the periapical radiolucency, radicular cyst, periapical cyst, abscess, granuloma, all the things. The clinical radiological entity, fenestration dehiscence present or not. Actually, inflammatory, actually pulp and periapical lesions is the bread and butter of our dentistry. So to assess that thing in confined way, if we direct go to the episectomy or hemisection or any kind of the endodontic surgery, apical surgery, first we need the CBCT assessment. How much amount of the endodontic approach is needed? How much amount endodontic approach is needed? How much amount of the area should be curated? The near anatomical structure, the nasoalveolar canal, the location of the nasoalveolar canal, all the things. The sinus, the close proximity with the maxillary sinus, all the things. The nasoalveolar canal, the position, all the things. Root fracture. The most missed one clinical feature, the root fracture. Actually, if there is any kind of presence of vertical fracture, and that actually causes the sharp shooting type of pain in patient after a successful treatment, or actually in various cases we face that lot of the patient come with there is nothing clinically. The clinically that is fine, all the things fine, but patient is complaining after a successful antibiotic, analgesic and antacid prophylaxis. Sir, my pain is not going. Sir, my pain is not going properly. Till the action of the analgesic is working, but during the chewing, I am suffering. I am experiencing a lot of pain, troubleshooting pain. What is the reason? I am seeing the IOPR, there is nothing, the all is fine. I am seeing the OPG, all is fine, but what is the cause? What is the cause? Then comes CBCT in the scenario. And we can find there is microfracture, there is accessory fracture, there is lateral fracture, there is horizontal fracture in the several types of the fracture in the coronal 1/3, middle 1/3, in any radicular surface, entoalveolar fracture, luxation type of injury in case of children, displacement, several things, alveolar cortical plate fracture, several things. Root resorption. Root resorption. To complete the endo obturation, it should not be the ideal destination, ideal pathway of our endo treatment. First, we have to assess if there is any kind of the external periapical root resorption is present or not, the gross periapical radiolucence is present or not, the appointment, the successive appointment with Metapex or MTA should be started or not, several things. Internal resorption has been started or not. To assess all the scenario, we require CBCT. To assess the post-operative healing, when we are placing the Metapex or MTA after pulpectomy, in the endo process, after a nice pulpectomy, and when we are finding a gross periapical lesion is present, the periapical radiolucence is present in the periapical relation with the tooth, what will be the ideal treatment procedure? We will obturate on that day? No, never. Intracanal medicament should be placed. There is placing of MTA or biodentin.
Excuse me, doctor. I'm sorry to interrupt you. Can you please check in your chat box?
Yes.
Yeah, sure.
After completing my presentation, I will give all the answers from the chat box. Na? So, what is the adequacy of the root canal obturation? The integrity of the root canal filling. The integrity of the root canal filling, 32 chat is deposited in the chat box. You can ask anything in, and after the completion of my presentation, I will answer all the things. Achha. Adequacy of the root canal obturation, the integrity of the root canal fillings, and the if any perforation is present or not during the massive access preparation, and during the deroofing, and during the removal of the dentin, the coronal portion of the dentin, we are decreasing the remaining dentinal thickness, and if any unwanted perforation is present, and if the patient is facing several pain, we all have to assess this type of things by CBCT. The integrity, what is the canal pathway? There is the canal morphology, the 1:2 canal, the canal is bifurcating in nature, there is diverging nature of the canal, the bended canal, the if there is pulp stone or present or not, several things we can assess. The missed canal, we can assess the missed canal here, we can assess the missed canal here. There is missing of the canal, obturation as missed up due to lack of the adequate radiological data from 2D images. Now, in the case of orthodontics, where CBCT is needed, we have already described, but in various cephalometric analysis for various cephalometric analysis to assess the facial growth pattern, horizontal, vertical growth pattern, airway, airway obstruction. Hello. Okay, 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 okay. There is few slides left. Okay, 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 okay. We will go rapidly. Uh, Actually, two or three slide I think left. Last topic to discuss, that is the CBCT in periodontics. To assess the amount of the bony defect, to assess the one wall, two wall, or three wall defect, to assess the bony pattern, to assess the various types of the cystic lesion, various types of osseous defect, amount of the bone present for implant planning. We require the CBCT. To assess the airway, means the oropharyngeal area, how much amount of the airway is present. To assess, we require the CBCT. We can conclude that we all the CBCT is nowadays there is wide application of CBCT, but we can't neglect the necessity of IOPR or OPG. In all the cases, we will not prescribe the CBCT up till we can work with IOPR or OPG. Mostly nowadays we use CBCT 5th generation. The exposure time is 5 to 14 seconds. The exposure time, actual exposure time, and the processing time is 2 to 3 minutes, means the acquisition time. The cost varies 1,500 to 6 to 8,000 also. The smaller FOV, means that is the single tooth or the single quadrant, that is the 5 into 5 centimeter FOV area. The largest is 10 to 15, actually 12 to 15. The smaller FOV produce greater contrast area, and vice versa. That is my reference. I have taken all the data. That the three books we all know, the White and Furrow, the classical radiology book, the cone beam dentistry CBCT book, the Springer, the gold standard book of CBCT. We can also follow the interpretation basis of CBCT by Blackwell. Thank you. Thank you, Indian Dental Association Student Education Program team, for giving me the platform to share the thoughts on CBCT with my with my colleagues, with the students, dental professional. Thank you all. There. Okay, I am now going to the chat section. Okay, you are audible. Achha. Okay.
If anyone has any doubts, you can type your doubts in the chat box. Also, for all the participants.
Any clinical doubt? There are all no clinical doubt actually. No clinical doubt actually. If anyone have any kind of clinical doubt, no, there is no clinical doubt. Dr. Sanjana, if you can ask any kind of clinical doubt, what is the margin of error of the CPCT, like the chances of artifacts occurring? There is actually each and everything. There is any kind of advantage also having the chances of the noise. We have to follow the classical rules, the Alara principle, the patient guiding, to avoid that thing. Any metal object should not be present. Ah, mm, Meeting is not audible. No, I was audible to all of you. Okay, actually, if we avoid all the things, Dr. Kaur, uh, we can avoid all the things. We can avoid all the things. But actually, due to artifact, actually due to presence of a large flat panel detector, large size of the detector, there is production of the scattering radiation actually. So there is formations of image noise, and we can limit or we can minimize by maintaining all the things, LRA principle, the patient protection rules, maintaining the removal of all the necessary things before scan. That's any question. Is the chance of error occurring uh, less than the chance of error occurring while taking IOPA? Is the chance of or panoramic? Is the chance of error occurring less than? Actually, in the case of IOPA or in the case of panoramic, uh, what the principle, general precautions we have to maintain. We have to maintain the same things in this thing also. The patient protection, the all the things actually, the basic things actually the same. The physics thing is totally different, but the basic patient protection and the guideline are almost same. There is also image distortion, lengthening of the image, image shortening in also in the IOPA. There is also the flattening of jaw. The resolution or contrast is less in panoramic view also. Panoramic view also. Nothing is absolutely the artifact free or anything else. Nothing can be also. Uh, Dr. Shidhu Varath has asked, what situation would you recommend CBCT over traditional 2D imaging in general practice? Sir, I have already, Dr. Shidhu, I have already mentioned several in case of disimpaction surgery, where, where we are not sure the angulation, the trajectory, the position of the impacted tooth during the disimpaction surgery. During the disimpaction surgery, the missed uh, canal in case of various types of the endodontic cases, the missed the microfracture, uh, various cases nowadays. It is so important nowadays for that reason. In implant planning, so they are necessary, but in uh, that cases we are routinely used to IOPR. In that cases also, uh, for the proper and methodological and the exact correct treatment procedure, we require the CBCT. Can we measure, Dr. Krupal Makwana has asked, can we measure the distance between the implant through CBCT? Obviously, there is several parameters actually. The software has all the things. Actually, I will suggest you, Dr. Krupal, to go through the any kind of CBCT software available in market. There is the several parameters, the measuring parameters actually. Can you explain? Dr. Ashish asked, can you explain implant distance? Actually, that's not not the topic I am going in details. Actually, we have to assess the implant. Actually, uh, listen, Dr. Ashish. Actually, when we are assessing the implant placement, before the implant placement, we have to monitor several things. What will be the distance between the implant surface and the naturally present tooth? What will be the inter-implant distance? What will be the distance between the inferior surface of the implant screw and the the proximal surface of the floor of the maxillary sinus, or the proximal surface or the superior border of the inferior alveolar canal. What will be the diameter? That is the actually the prosthesis things, 1.5 to 2 millimeter, the 1 to 1.5 millimeter in between the implant. They are the several, they are the difference things actually. Dr. Monica has asked, uh, in TMJ abnormality, do we have to advise open and close always? Actually, open and close CBCT. No. They are uh, actually, Dr. Monica, first clear. Let me clear the idea. Open and close CBCT is not persisting. The open and close TMJ view, they are the normal classical extraoral view. CBCT has no specification of open and close view. CBCT not related to CBCT. Open and close TMJ view is normal extraoral view. We can operate it with the normal OPG machine that is not linked to CBCT to assess the condylar position. Dr. Guru Charan Singh, can you please provide the slides of link, PDF or video link? I can provide the slide link. Dr. Sanjana will guide accordingly. Dr. Singh, how is
Yes,
it?
doctor. This webinar is live on YouTube, so you can always access this webinar from our YouTube.
Okay. Dr. Singh, you can access the webinar through the link, YouTube link. Dr. Sanjana will upload uh, the link. Dr. Subham, how to identify the tubercle salivary gland, which is recently discovered by scientists. Dr. Shubham, I have limited idea about the tubercle salivary gland. That is on the research uh, state, I think. Sorry, I can't share uh, no information about the tubercle salivary gland. Sorry. Actually, we can see the shadow of the salivary gland. The actually the submandibular, the existed, we have existed major salivary gland, the submandibular salivary gland fossa. We can assess all the things, but actually the soft tissue resolution is not prominent. We have already discussed earlier. The soft tissue resolution is not prominent in case of CBCT when we are comparing with medical city. But we can assess. I can tell you we can assess that one, please. Dr. Parag, which one I have to answer? Which one? Doctor, please mention Parag. Dr. Parag.